Hello and welcome to our discussion today. My name is Valerie Cordero. I am co-executive director of Families for Depression Awareness. We are a national nonprofit organization that helps families recognize and cope with depression and bipolar disorder to get people well and prevent suicides. You can find out more about our organization by visiting familyaware.org. Today, we're going to have a great discussion with an expert, Dr. Craig Chepke. The topic of conversation today is depression and anhedonia. So welcome, Dr. Chepke.
Thank you very much. Glad to be here, Valerie.
Glad to have you. I'm going to read a little bit about you and then we'll get started. Dr. Craig Chepke is a board-certified psychiatrist and the medical director of Excel Psychiatric Associates in Huntersville, North Carolina. He is also an adjunct associate professor of psychiatry for the Sandra and Leon Levine Psychiatry Residency Program at Atrium Health. He attended NYU School of Medicine and completed his psychiatry training at Duke University. Dr. Chepke has been recognized as a distinguished fellow of the American Psychiatric Association. So to start, Dr. Chepke, can you please just give us first the clinical definition of anhedonia, and then tell us what it actually looks like, or give us the non-clinical sense of what anhedonia is.
Sure. So, like a lot of terms in medicine, we have to make things overly complicated and use foreign words with either Greek or Latin origins. This one it comes from Greek. An is often used to mean the lack of or not having something. And hedonia is related to a word that a lot of people might have heard, hedonia, hedonism. Now, when we think of hedonism, we often think of someone who is excessively pleasure seeking, someone who maybe goes to Vegas and parties and does expensive bottle services, all kinds of silly things like that. And so anhedonia is a lack of desire to want to do things that are pleasurable by the literal definition. But really, that's not exactly what it means, because it's not such a bad thing if you don't want to go and party hard like that. A better way to define anhedonia is a different degree of a lack of not just desire to want to do things that are pleasurable or feeling fulfillment in doing things that are pleasurable, but also things that bring fulfillment, like playing with your children or going to your job and doing a good job at it, being around friends, doing hobbies that were interesting. And so it's really a much greater and more kind of dangerous type of symptom, because it really involves the motivation to want to do anything, or it's really linked together. There's two sides of the coin. One is the desire to want to do something that will bring joy, fulfillment, pleasure, things like that. And then once you do them, if you don't feel pleasure from actually doing them, you're not going to want to do them again. So it can be a vicious cycle. And individuals might have both sides, that they don't want to do anything, and they don't feel any better when they do it. Or it could just be one or the other, but they really feed against each other.
And in terms of what family members notice when a loved one is dealing with depression and the different symptoms that appear, does anhedonia tend to be something that family members notice, or are they usually more able to notice the sadness or an irritability before they'll notice that lack of joy or fulfillment or interest in doing things that the person loves?
You make a really good point. And when most people in the United States, at least, I can speak for our culture, when we think of the word depression or an individual who's depressed, then we think of sadness, and it's just a reflex muscle memory. And that's possibly in part because, as a profession, psychiatry hasn't done a great job about educating about different symptoms of depression, and we've kind of let the sadness take the narrative. Now, it turns out that if you look at the diagnostic criteria in the DSM, the Diagnostic and Statistical Manual, which is put out by the American Psychiatric Association and what we base generally our diagnoses off of, there are 9 different symptoms that may be associated with major depressive disorder diagnosis, and you have to have 5 out of 9 of those symptoms. But here's the part that a lot of even healthcare professionals don't think about often enough. One of those 2 symptoms has to be either sadness or low mood. Check, that one's easy to understand conceptually. Or it has to be a lack of motivation and desire to do things, anhedonia. So even though we predominantly as a as a healthcare profession and certainly as a culture think about depression being synonymous with sadness, you can actually have a major depressive disorder diagnosis really without being overly sad and low mood, as long as you have anhedonia. It is co-equal as one of the two most important symptoms of depression. And in major depressive disorder, about 3/4 of individuals have anhedonia. Now, that's a long-winded prelude, but I think it's important backstory for everyone to understand. That being said, it kind of fades into the background. And so family members, just like the individual with lived experience, doesn't really know what to make of it, because their whole thought process and conceptualization of the condition of depression is being sad or having low energy. Sleep problems are some that are commonly known by most people. But this lack of motivation, most people don't really realize that that's part of depression, and it can be masked by other things as well. So it's hard for a family to notice something specific about that if the individual doesn't, although it can work the other direction as well. The person who has the lived experience might not realize it, but the family says, well, you don't do anything anymore. And this can extend not just to examples that I gave earlier, like wanting to play with your kids, going and doing your job, things of that nature, even just basic hygiene, wanting to get up and take a shower, brush your teeth, comb your hair, things of that nature. It can be really affecting the bedrock of what we call the activities of daily living in medicine. And the person who has the lived experience thinks, well, yeah, why would I want to do those things? I'm depressed, and it might not seem abnormal to them in some cases, but the family really realizes, wow, this is just not quite right. And because there's that lack of awareness, there's a lack of generally ability to communicate that well. We don't have the language for it. Most people, we don't have the vocabulary. We know how to talk about sadness and feeling tired or sleepy or some of the other symptoms of depression, but how do you talk about anhedonia? I mean, very few people outside the medical profession know that term. I've heard of it before. That's one problem. But even how to describe it is very difficult for a lot of people. So a lot of people that I see in my office, they don't specifically say, Dr. Chepke, I have this, and it's anhedonia. But they'll say things that are kind of like breadcrumbs that lead me to realize that's what's happening. It's often very vague and non-specific. I just don't feel like doing anything anymore. That's a really common one, or some variation of that theme. And it's not one specific thing. A lot of times healthcare providers may ask screening questions for depression about, do you enjoy your hobbies like you used to? And that isn't a terrible question, but it's incomplete, because that only addresses the one side of the coin I mentioned about the enjoyment of an activity, and doesn't get at the root of, do they want to do anything pleasurable or fulfilling or that brings them joy, as I mentioned. And so if they're not doing those things, then they can't enjoy them. So it's missing the boat. There's a lot of the two ships crossing the knife phenomenon when it comes to assessing anhedonia, I find.
And what you're saying also leads to why there can be a lot of stigma and shame put on people who are experiencing
Mm-hmm.
these kinds of symptoms. Wow,
Yes.
Dad, you used to like to come to my games. You wanted to
Mm-hmm.
be there and cheer me on. Now you don't want to go. Or if we drag you there, you don't seem like you want to be
Right.
there. And so,
Right.
from the family perspective, they're seeing it
Mm-hmm.
as, you're not the dad I used to know, or you're not the
Exactly.
sister who used to support me the way you did. And so you've already kind of touched on this, but I wanted to talk about how this symptom can impact people's daily
Yeah.
lives, and how that can look different than sadness. Because I think to a certain degree, as you were saying, we have a language for talking to people about
Mm-hmm.
being sad. It's, oh, you're sad. You can still feel, people can still be
Right.
frustrated by that person being sad, but we have a language. That lack of motivation, people can see it as, oh, you're being lazy. So their approach to you,
Bingo. You
talk to
took the
you
words out of my
about,
mouth. You're lazy. You gave up. Are
yeah.
things that I've heard patients tell me in the past that they've been told by family members or loved ones.
So yeah, can you speak a little bit more about that impact on the person's life, which is a little bit different than if they were feeling that irritability or anger or sadness? Those still could be problems for the family,
Mm-hmm.
but how do people's lives change because of that symptom?
Yeah, this is a fantastic question. And it's in general, it's a lot easier to see something that is there that shouldn't be there, like sadness, like irritability. And we could go on and with any diagnosis. that it's a lot easier to see something that shouldn't be there than to not see something that should be there. We sometimes in psychiatry call that a negative symptom because it's something that should be there but isn't, and it oftentimes can elude our detection. That we see, okay, well, man, they blew up at me. They're irritable. They're crying. They're sad, but not knowing that, well, wait a minute, they should be motivated to do this. They should want to. They used to be really eager to go to the ball games of our kids or things like that. That's a lot harder for, I think, just the human brain to perceive. Nothing to do with anything related to a mental health condition, but uh, human psychology, the way the brain's wired, it's harder to find those things that aren't there that should be. And that can breed a little contempt, especially because anhedonia is oftentimes a residual symptom of depression. That when someone does get treatment, or whether even if they didn't get treatment and they were fortunate that the depressive episode gets better, anhedonia is often for many people one of the symptoms that doesn't get better, even when other symptoms of depression do. So someone can be less sad and less irritable, and then the anhedonia maybe doesn't improve much, or maybe doesn't even improve at all for some people. Some people, don't get me wrong, do have resolution of anhedonia, but unfortunately, it's pretty common for it to be a residual symptom after there's been at least a partial response with some sort of treatment. And that can really be frustrating to family. Hey, look, you've made so much progress. You're not in the bed in the fetal position crying anymore on a daily basis. You're not snapping at the kids anymore, but now you won't even go and play catch with them. You won't, when I come home from work, you don't get up and give me a kiss or say hi. What's wrong? What are we doing wrong? And that can also, as I said, breed some contempt, and the family members can sometimes be angry at the individual because it is sometimes perceived as laziness or not caring, when it's nothing at all that the person would ever choose.
Do we know why that particular symptom can linger longer than other symptoms? Does it have to do with brain chemistry, or why is that something that can persist even when maybe the sadness
Mhm.
is getting better, or the isolation is getting better? Why does that? Do we know, first of all, do we know why it lingers? And if we do know, why is that the case?
Well, anything in psychiatry, I always have to caveat that we don't really know anything in the brain. We have a lot of theories, but the brain is the most difficult organ of the entire body to study. It's got 85 billion neurons with trillions of connections between those neurons, and all of it is wrapped in a big, thick, bony skull that we can't even get to it. So neuroscience is quite a bit behind other fields of medicine like cardiology or gastroenterology or things like that can get to their organs a lot easier. So one of the theories that we have, at least in regards to treatment, is the treatments that we have for major depressive disorder are often things like SSRIs, SNRIs that block the body from reabsorbing serotonin and norepinephrine. Sometimes we have treatments that work on dopamine as a neurotransmitter. And those are all very closely related neurotransmitters. And they only form a small percent, less than 5% of the amount of the total neurotransmitters in the brain. So if that's all we're working on, then there's a 95+% potentially of the neurotransmitters that we're not directly working on. Um, Everything in the brain's connected, like the leg bone's connected to the hip bone type of situation. So if you do interact with those neurotransmitters, eventually you get with serotonin, dopamine, norepinephrine, it does impact other neurotransmitters as well. But we don't have a whole lot of treatments that go beyond that. In the past couple of years, we've started to get a couple that don't work directly on one of those three major neurotransmitters. But that would probably be the best theory, is that the tools that we've had for the past 70 or so years just haven't been acting on the right neurotransmitters necessarily, potentially, to be able to have the right effect, to have a benefit on those symptoms in the same way they do the sadness and energy levels and things of that nature.
I'm sure it's so hard as a practicing provider to tell people this is what we think. We still don't know, but we're trying this. But
Mm-hmm.
that's
But it's
why
good to
it
have
is.
humility. I don't want to ever project that I know everything or anyone knows everything about the brain. We still have so much to learn.
Yeah, I think that's why it is important that continue to research and talk about these
Exactly.
issues, because uh,
Mm-hmm.
there's still so much that's unknown.
Yeah.
I'd like to set up what the stakes are here. So,
Mm-hmm.
in general, we as an organization know that untreated depression generally can have serious consequences on the person's life, on their interpersonal relationships, can even be life-threatening if somebody leaves depression unaddressed. If somebody were to say, oh, this lack of motivation is it's just who they are now, and just discount it ever getting better, what would be the danger of that? I'm sure there are interpersonal dangers to leaving it unaddressed. So can you just kind of set the stakes for why it's important to recognize a symptom and make sure that it's being addressed within the person's treatment or within their family relationships, and working forward in therapy and trying to mitigate the depression? Why is it important?
Yeah. So all the things that you mentioned, the difficulties of quality of life, work, relationships, and suicidality as being as depression is a risk factor for those potential outcomes. All of those are true also about anhedonia, but in a way, what we call an independent risk factor, because anhedonia is can be one of many symptoms of depression, and you put all the symptoms of depression together, and they're a risk factor for all of those negative consequences. But if you can separate out that regardless of the severity of the overall depression, whether it's mild, moderate, or severe, that independently anhedonia acts as a risk factor for all of those that you mentioned. There's good data that there's people with prominent or residual anhedonia have lower quality of life than those who do, compared to those with depression that is matched for the same level of severity and other matched for other factors, have a worse quality of life, lower functionality. They have a slower time to get a response or remission. They have a greater risk of relapse, and there is an independently elevated risk of suicide as well. So it's not just one, it is one of a whole, but it's a very important one, and almost can be additive and maybe in a way you could call it like synergistically worsening the risk of all of those consequences. And so even if the others get better, it still is going to remain equally as high of a risk factor as it was before for all of those potential negative outcomes.
Thank you for that explanation. I think the main takeaway from what you just said is that it's overall important to be addressing depression when it's untreated. The symptoms might be different from one person to the next, but the dangers of leaving it untreated far outweigh the stress of the trial and error process of finding the right providers, finding the right therapy, finding the right treatment. It's worth that, because leaving it unaddressed is very dangerous for somebody's overall
Exactly.
health and relationships. I'd like to switch gears a little bit. There's been a lot of talk in recent years about brain-gut connection, the connections between digestive health and overall health, and particularly mental health. So I'd love to know, is there any connection between gut health and anhedonia? Is there no connection whatsoever? Just wanted to hear your thoughts on that topic generally.
Yeah, and as I mentioned before, I can give you theories, and I think there could be a line drawn between the gut health and anhedonia potentially. This is something I would say doesn't have as much evidence and backing as a lot of the other things that I've talked about today. But we know that in many mental health conditions, and depression being maybe one of the cardinal ones that we think about this theory, is about inflammation. That we have lots of evidence that inflammation has some sort of a negative effect on certain types of inflammation. Just like everything, there's good inflammation, bad inflammation, and certain negative types of inflammation can be associated with worse mental health outcomes, including for depression. But specifically, there is a potential connection. There's a little bit of evidence that could link inflammation as a through line into anhedonia. And gut health is very often associated with inflammation. So that's where I would say there could be a potential link, but it wouldn't be something that I would say you take care of the gut health and it's going to make the anhedonia go away. Again, these things are really multifactorial. There's so many different factors that we have to look at, but certainly as part of an overall holistic treatment plan, I think most people with mental health challenges, and especially major depressive disorder, should be looking after things that could improve inflammation, diet, exercise, things like that, getting appropriate sleep. All of those are anti-inflammatory. So while we have lots of anti-inflammatory treatments for other conditions, but there is currently no anti-inflammatory medication that has been shown beneficial for depression. But those lifestyle types of interventions and changes can have definite benefits on systemic inflammation and therefore the neuroinflammation that goes to the brain, and we think may have negative consequences.
So bottom line, practice good lifestyle to help improve your
Yeah.
physical health as well as your mental health. We just can't get around the good balanced diet, the exercise, the sleep hygiene, getting lots of sunlight, just all the
Mm-hmm.
good things that we should be doing for our health anyway. So we at Families for Depression Awareness really believe in giving caregivers strategies for addressing the issues of mental health that might be affecting their families. So my next couple of questions are about giving some concrete strategies to families. So first of all, how can family members support a loved one who's experiencing this lack of joy, lack of motivation? What's the role of the caregiver there in supporting a loved one through that?
Well, I mean, as you know, this would talking about how care partners interact with people with depression could be a whole topic in and of itself. But I'd say if to narrow it down and maybe give kind of one pearl would be to, as I mentioned, there could be some friction and conflict in a relationship and feelings of resentment, possibly that the person doesn't uh, keep up with the relationship or the parental relationship or whatever it might be the way they did before. And I think a great way to handle that is, and this is hard for the person who is the care partner to do, but kind of think about the depression and the anhedonia as a third person in the room. Like this is, look, it's you and me against the depression, against the anhedonia. I know this isn't you. This is the anhedonia talking. I know you say you don't want to go to our daughter's softball game, but that's the anhedonia talking, not you. And I think that approach can be helpful for both partners in that relationship, for the individual with the depression and also for the family member as well, because it externalizes it. It makes if you can really believe it and get into it, that it's a common external enemy and not something that is just how I am now or something like that you mentioned earlier. So put that as the common enemy that you both bond together to try to fight against.
I've heard somebody describe it as the monster. It's like the monster's
Yeah.
coming, and we're
Mm-hmm.
we're both working together to keep it at bay or to get rid of it.
Right.
And by separating it from the person, you know that the person that you love, whether it's your sister, your cousin, your parent, you know who they are. And these side effects of having depression, these symptoms,
Mm-hmm.
these changes in their behavior are different than who they are. So by separating it and working together to address those issues, you are also affirming, I think, for your loved one that they are still the person that they love. You know, you're still
That's
the
right.
mom I grew up with who I love.
Mm-hmm.
We're just going to have to see how we can address this external depression or anhedonia or whatever the symptoms are, and doing it together. And I'm in it with you. I think that's helpful to families.
That's right.
A lot of people's first contact with a medical professional around their depression is a primary care
Mm-hmm.
provider. So it could be somebody who has a general working knowledge of mental health and has a few things that they know how to do to work with a person, a patient who has depression, but they may not know the ins and outs of anhedonia like a psychiatrist or another mental health professional would. So how would you, let's say you're able to go into that appointment with your loved one and they're dealing with their depression and they're not able to communicate like they would if they were not depressed at that time. How could you initiate that conversation with the provider? What kinds of questions could you ask, or what kinds of things would you need to know ahead of time in that appointment to make sure that they understand what your loved one is going through? If, of course, you've gotten permission to be there and you are playing that role in being that supportive care partner in those appointments.
Well, first off, I just want to say I think that's a great idea for people to go in with a family member, close friend, someone who knows them really well, to talk about mental health because that there's a kind of a stereotype, and I encountered this in my training that a lot of psychiatric professionals feel like, oh, I only want the person that the one person in the room. You know, there shouldn't be anyone else. It should just be the healthcare professional and the individual, and that I don't, for me, at least as a psychiatrist, that doesn't work well. I see the vast majority of my patients with a spouse, child, sibling, a parent, close friend, whatever. because everyone's got blind spots to themselves. That's why healthcare providers can't prescribe to themselves, because we can't make the type of logical judgments that we need to prescribe medications when it's about ourselves. It's felt to be not possible. And that's the case with people with mental health challenges as well, that they're going to have some blind spots. And the other third party in the room that knows them well can help to fill in some of those gaps. I talk about it with people who come to see me as it's like the difference between a two-dimensional X-ray and a three-dimensional CAT scan. I want to get that extra dimension of information in order to better help you. It's not that I don't believe you when you're telling me things on your own. It's just that it's impossible to get a 3D image from a 2D scan. I need that third dimension. So just that I can't help but talk about that, because I really encourage people to do that if at all possible. And really, knowledge is power, and knowing the word anhedonia. I mean, primary care providers, as you said, they are not specialists, and man, they're overworked. They've got to know, they can only know 3 things or 4 things or 10 things about psychiatry, because they have to know 3, 5, 10 things about cancer and asthma and irritable bowel syndrome and every illness under the sun. It's impossible to know everything about everything, and they do the best they can, and they do a good job of it in most cases. So while they might not be proactively screening for anhedonia necessarily, they have heard the word. And so if you know the word and you think that could be a symptom you're experiencing, just asking, I heard about this symptom called anhedonia. Do you think that's something that I have? And that can open the door, because once they know that, okay, well, let me ask about that. Even if they're not specialists and experts, they can at least direct their line of questioning down that avenue and get to some better information to better help you.
So there are still things that could be done to help families,
Yes.
particularly people who are dealing with depression and anhedonia. I think the other big takeaway I'm going to have from this conversation is that there is a role that family members can play to support their loved ones. It starts with understanding, having the knowledge, having the information, and
Mm-hmm.
using supportive language to talk about these issues. You can play a role in making sure your loved one is seeking care and getting the best care possible. And then you can be the one who is educated about these issues, because
Right.
depending on the provider you see, you may have more information or more up-to-date knowledge
Mm-hmm.
about it than they do, because it's your loved one and you care about them. So we should have
Exactly right.
hope and be sure to know that there's a role that family members can play, and that your loved one doesn't have to just suffer with this condition without having any help. So thank you so much, Dr. Chepke, for sharing your expertise with us today. We hope this conversation was helpful to everybody watching, and we encourage you to visit familyaware.org for more resources. Thank you so much.